So now we are going to operate a case which was operated previously and 5 years back. Now the patient has the open surgery was done. Now the patient is complaining of radiculitis on left side of the body, left side of the leg. So we are going to do a foraminal on MRI. We have a foraminal stenosis. Open surgery was done previously. Now we are going to do a para UBE on the affected side. Both levels 4, 5, 5S1 we are going to operate. I will share the scans with you. Take a shoot. How we do para UBE? This is what I do. I do directly landing on the TP landing para UBE, which is one of the very predictable ways of doing it. So, but you should learn how to do it so that you can do the surgery faster. So, first we took a incision there where you put the pedicular screws. The same way you just put it there, take a palpate the TP, shoot, shoot, shoot. So now I am palpating the TP, take a shoot. Once you palpate the TP, your half of the work is done. Now we are palpating the TP, now we will do the dilatation. Increase the height of the C-arm, shoot. So this is the foramen, you can see. I directly palpate the foramen, everything. Everything is in my hand. So done. So we are landed on the TP and the foraminal areas. Take a shoot again. Yes. Yes. So that is that will cause a clear area for a landing point. Once it is done, take another mark in the inferior area. You can take on the pedicle. You can take anywhere you want depending on the pathology. So this is the second incision directly on the inferior TP. So TP landing is a easier way of doing the surgery. Shoot. Again on the same area, shoot. Dilatation.
Again you feel the same.
Yes,
point.
same. So I have just make the TP mute and then we start the surgery. Now two portals are created, 0° scope with a front throwing cannula, and once we are done with the landing we will remove the C-arm. Align please. So we have landed, you see the TP here. Okay, take out the C-arm. Coagulation. Shoot, take a shoot and take out the C-arm. Coagulation. Naturally this was an operated case, so some degree of scaring you will definitely shoot. Shoot. Okay, so we are exactly on the TP. Take out the ablate. So you can see these are the scar tissues of previous surgery. Stop. The TP is broken or what? Looks like the TP is broken. Ablate. Sometimes the TPs are broken. Stop. It's a broken TP, you see, maybe from the previous coagulation. And you see the scar tissues and everything, which is quite common. Ablate. But you should understand the foramen is here. Stop. Ablate. Okay. Public. Now we know the foramen is here, so we'll start working on stop. Building. So this is the foramen coagulation, and this is a mammillary process you can see here, and this is a broken TP. Stop. Drill. So you drill the foramen. So started drilling the foramen here. Take a shoot. Coagulation, please. Coagulation. So this is the foramen. You can see very well. Stop. Drill, please. Take out this. Bring the C-arm in, just to see where exactly are the foramen or not. Coagulation. You see a lot of vessels. Coagulation. So revision cases are wonderfully done with biportal, especially the foraminotomies. Shoot. Shoot. Shoot, please. Coagulation. Okay. So this is the foramen. Coagulation. Alright. Stop. Hook, please. So in this area you have to be gently around the, so this looks like to be the root. Okay. So you have to be very careful in these revision cases where we expect coagulation. Saline. Coagulation. Okay. So hook, you have to be very gentle. Now we see the root and we will do some foraminal work now. This looks like to be a root because it is thick. Coagulation. Saline. Coagulation. Stop. Coagulation. 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 Carrison view. Curved carrison always in these areas because it's a foraminal work. You see the root, it was already exposed. Give me the rotating carrison. Carrison. So the root is already exposed at the part of previous surgery. Saline. Crowd correction, please. Short, you see this is the foramen. Okay. Good. I believe the foraminotomy was done before. Root is, yes. You see, this is how previous foraminotomy looked like. So, the disc. Correlation. Saline, correlation. Stop. Okay, correlation. Stop. Correlation. Correlation. So naturally you advance the foramen to a deeper extent so that you can see the compression. This is a revision case, definitely operated elsewhere in another city. Right. Bigger hook, please. Correlation. 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 So while operating this area, you have to be very careful. Sometimes you don't know what was operated last time because you are not the primary surgeon in the last time. So you have to be very careful around these areas because sometimes the root will be exposed and you have to be very gentle so that you get okay bigger hook, and job is to see whether it is going. Here it is also going, but I need to see this area. Calcium. Bigger calcium. Saline, please. Yes. So this is the area you need to explore, the axilla of the nerve. Okay. So I am going towards axilla of the nerve. That's the area which will give the best of the work. Bigger calcium, please. CT, you always should look for any spur Pedicle has spur. Okay. Cure it, please. Saline. So I am making the foramen wider, which is known as foraminoplasty. So foraminoplasty will give some adequate space to the nerve. Okay. Saline. Yes. Okay, saline please. Smaller one you give. So the foramen should be adequately decompressed, otherwise there will be issues with the patient. Garrison. Hook please. So this is the nerve. You should see the nerve is free or not first. Looks free now. Saline. Coagulation. 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 Stop. Okay. Cure it. So we are seeing the nerve. This was an exposed nerve. You can see it is discolored, and the internal nerve is better now. So we are going deeper inside the canal. Otherwise, getting results will be difficult. So this is a disc you see. Drill though. Give me a drill. Saline. So this is your pedicle. So you can see this is the pedicle. Huh? This is the pedicle. This area. Okay, this is the pedicle. Saline. Okay. Chisel though. But it is not going, so we have to work more now. Okay. Garrison, cure it. So in these cases, curate is a very important and handy instrument. We see the nerve very well, but this foramen has to be widened till deep. So you see, this is the pedicle, huh? This is the pedicle.
Yes.
Okay.
Yes.
The pedicle, huh?
Yes.
Take a shoot, you will understand. Take a shoot. See, I am just in the pedicle, just little
Yes.
away from the.
Yes.
So everybody can saline, everybody can appreciate the pedicle here. Okay, take a shoot, take a picture image. Take an image of pedicle.
Shoot.
Take image. Okay.
Yes, sir.
So little more of the foraminal work, my job will be over. Okay.
Yes, sir.
Little of the pedicular drilling also sometimes helps. Okay, so I'm widening the foramen. Saline? Yes. You see how I'm widening? I'm scooping out all the foraminal bone which are unnecessary at present. Okay. Now it is a small hook. Now see, the hook is going in. Okay. This process. No, this is curate. Curate hook. Position. Good. Saline.
Correct.
Good. Good. Check. Okay.
Yes, sir.
And here also sometimes you should see, because this is also better. Root is also mobile. You see, saline. Root is also mobile, and you can enter the foramen well. A little more of the curative is needed. Calcium. Do not stop till you find a better curate. Job is not over. Saline, please. Calcium. Saline. Obliterate. Curate. Saline. Shut over. Curate the. You see. This work is very important. Okay.
Yes, sir.
So now you get a little relaxed root. Hook the hook. Now this is a phlegm. Just need to remove it. Curate. Carry something. Little curved curate is needed. Saline. Okay. Yes. Okay, very good. Okay. Epidural fat has come, huh? Okay. Curved, little more curved. Chal, okay, done. Okay.
This much winter, no procedure we can go.
Hmm. Okay.
You will do discussion, sir.
No, it's okay. No, fine, better. Okay. Yes. So now we are complete with the procedure of foraminotomy of this level. So now we are going to start. We are operating on the next level, which is L5S1. Shoot. Shoot. Okay. Level and another incision down, just to identify. Okay. Dilators. Now shoot. So now you see we are arrived on the foramen of this level. Shoot. Shoot. So same way, the way we are doing, we landed on the TP of the L5 and scraped and made a position for the TP landing. Now for the inferior part. Shoot again on the TP. Shoot. In these cases you may have to drill the TP a little. Shoot. 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 Okay. Again we will start the para UBE of L5S1 level. Kindly understand, this is a foraminal surgery where the revision cases shoot. So you see we have landed on the TP now. Take a picture of there. We have landed on the TP. Here also we have landed on the TP. Coagulation. Saline coagulation. Saline. Stop. Hold. Okay. So this is the TP area just below coagulation, just below the ablet. just below the TP area you will get the foramen. Okay, so this is the area ablet. This is the area for the foramen. So I'll drill ablet. So I'll drill this area. Okay, drill please. Shoot. Just below the foramen. Huh? Coagulation. So lot of oozing do happen, which has to be taken care by generous saline, generous ablation, coagulation. Saline. The oozing sometimes can be cumbersome, but can be taken care by generous ablation, coagulation. So now we have identified the bleeder. You see it is here. Stop. So there can be small bleeders, but when it bleeds, it looks very torrential because in water. So whenever we will keep on drilling, shoot. Coagulation please. Again it is oozing. First thing is for control of oozing is so oozing is only from here, coagulation. But you just need to identify it. Stop. So you see it is going to the foramen. This is the foraminal ligament. This is the foraminal ligament. The nurse needs to drill it. So we drill it by a rounding motion essay, like a C. We drill it from like this. Okay. Shoot. See, the bone drilling is very important in these cases. So I am drilling the superior articular process, and this is the foraminal ligament. Without this drilling work, it is not possible to open up the foramen, especially in L5S1 level. So I am drilling the superior articular process. Sometimes oozing do happen. Do not worry about this. RF plasma is a much better coagulation device, and in saline it is very easy. Ablet. Stop. So these are bony oozing coagulation. Okay, stop. So a little more of the drilling curate. So you see I am entering the foramen. So this is the area where you have this SAP IAP junction. So I was drilling the SAP, but you see this is the joint, and this is the area which was, you see Mawai. So this is the foraminal ligament. I am lifting. I call it as an orange peeling mechanism. To peel the orange. Is Harrison, please. So below it, you see how the problem is here in this cases is the overriding, which is a normal phenomenon in alpha S1 level. Okay, Harrison bigger. So now I have bigger Harrison, normal Harrison, please. Only in here these cases normal Harrison is needed. Rest all cases done, work done. Third Harrison. Correlation. 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 Harrison. See, I am inside the foramen now, and the root is seen, and we have completely done a wonderful decompression of the foramen. So I will summarize my surgery at the end of this foraminotomy. It is a fast, effective technique. Now you see the root very beautifully. Okay. Hook, please. Correlation. Hook. Correlation. So this is the superior articular process. This is the joint space between the two. This is the disc, and this is the root, and this is the foramen. Correlation. So we are done. A wonderful decompression of the foramen. Everything looks better now. Hook. Bigger hook, please. You see how free is the foramen? Very free. Bigger artery also, enter it is going. Okay. So now the foraminectomy over for this. Thank you so much. Thanks for.